Welcome to NSG 229, Study Session 17, The Management of Pneumonia. Introduction. The setting in which pneumonia develops is one of the most important features to doctors. Pneumonia may develop in community-acquired pneumonia, or in some other institutional setting, such as a nursing home. Institution-acquired pneumonia. The settings often help determine what infecting organism is responsible for the pneumonia. For example, community-acquired pneumonia is more likely to stem from infection with the gram-positive bacterium Streptococcus pneumoniae. In this study session, in procession of previous studies, we'll focus on the management of pneumonia. Learning outcomes. At the end of the study, you should be able to 1. Discuss the management of pneumonia. 2. Describe the nursing intervention. Management of pneumonia. Hospital-acquired pneumonia is more likely to be caused by Staphylococcus aureus or a gram-negative bacterium, such as Klebsiella pneumoniae, depending on the infecting organism. There is usually a difference in the severity of pneumonia and the way it is treated. Mark, Andrew, Thomas, et al., 2003. Pharmacologic therapy. The treatment of pneumonia is administration of the appropriate antibiotics as determined by the results of the Gram stain. Penicillin G is clearly the antibiotic of choice for infection with S. pneumonia. Other effective medications include erythromycin, clindamycin, the second and third generation cephalosporin, etc. Treatment of viral pneumonia is primarily supportive. Antibiotics are ineffective in viral upper respiratory infection and pneumonia and may be associated with adverse effects. Antibiotics are indicated in viral respiratory infection only when a secondary bacterial pneumonia, bronchitis, or sinusitis is present. Antipyretics may be used to treat pleuritic pain and fever. Antitussive medications may be used for the associated cough. Warm moist inhalations are helpful in relieving bronchial irritation. Antihistamines may provide benefits with reduced sneezing and rhinorrhea. Nasal decongestants may also be used to treat symptoms and improve sleep. However, excessive use may cause rebound nasal congestion. Treatment of viral pneumonia, with the exception of antimicrobial therapy, is the same as that for bacterial pneumonia. The patient is placed on bed rest until the patient shows signs of clearing. If hospitalized, patient is observed carefully until clinical condition improves. Hydration is a necessary part of therapy because fever and chilblain may result in insensible fluid losses. If hypoxemia develops, oxygen is administered. A high concentration of oxygen is contraindicated in patients with COPD because it may worsen alveolar ventilation by decreasing the patient's ventilatory drive, leading to further respiratory decomposition. Respiratory support measures include high oxygen concentrations, endotracheal intubation, and mechanical ventilation. Prognosis. With treatment, most patients will improve within 2 weeks. Those who may be more likely to have complicated pneumonia include older adults or very young children, people whose immune system does not work well. Complications. Almost all pneumonia cases generally run as uncomplicated course, although complications can occur in individuals with other risk factors and underlying chronic disease conditions. It may include atelectasis, shock, respiratory failure, pleural effusion, pleuritis, lung abscess. Shock. This is encountered chiefly in patients who have received no specific treatment or inadequate treatment. Corticosteroids may be administered parenterally to combat shock and toxicity in extremely ill patients. Atelectasis. It's characterized by collapsed or hairnet alveoli of one part or lobe may occur. This may occur at any stage of acute pneumonia and can be cleared with effective coughing and deep breathing. Pleural effusion. A condition in which fluid collects in the pleural space can occur. Usually, the effusion is sterile and reabsorbed in 1 to 2 weeks. It also requires aspiration by means of thoracentesis, pleuritis lung abscess, respiratory failure, e.g. acute respiratory distress syndrome, ARDS. Prevention. Pneumonia can be prevented by doing thus. 1. Advise the patients to avoid using antibiotics indiscriminately during minor viral infections because this may result in upper airway colonization with antibiotic-resistant bacteria. If the patient then develops the causative organisms of pneumonia, may require treatment with more toxic antibiotics. 2. Encourage pneumovax, pneumococcal vaccine, and annual influenza vaccination where available for high-risk patients such as those with chronic obstructive pulmonary disease, chronic heart disease, or sickle cell disease. 3. Urge all bedridden and post-operative patients to perform deep breathing and coughing exercises frequently. Reposition such patients often to promote full aeration and drainage of secretions. Encourage early ambulation in post-operative patients. 4. To prevent aspiration during nasogastric tube feedings, elevate patient's head, check the tube's position, and administer the formula slowly. Keep the patient's head elevated for at least 30 minutes after the feeding. 5. All infectious disease should be promptly treated and managed well to prevent hematogenous spread to distant areas in the body. 6. Educate on the use of face masks where needed. 7. Vaccination. Streptococcus pneumonia can be prevented with pneumococcal pneumonia vaccine. 8. Force feeding in children should be discouraged because of the risk of aspiration. Pneumococcal vaccine. From www.vaccination.infformation.org/pneumonia.com, 2 types of pneumococcal vaccines were identified: pneumococcal polysaccharide, pneumococcal conjugate vaccine. Pneumococcal conjugate vaccine 7, PCV7, was licensed in early 2000 and in 2010. A new PCV17 was licensed and replaced PCV7 for use in the routine vaccination of children. PCV13 offers additional protection against the types of pneumococcal bacteria that cause the majority of invasive pneumococcal disease in the United States. PCV13 is recommended for use in preventing pneumococcal disease in infants and young children beginning as young as 6 weeks. Control. To control the spread of infection, educate patients to cough and sneeze into a disposable tissue and dispose properly. Set a lime bag to a side of the bed for used tissues. Dispose of secretion properly. Nursing management. Nursing process, nursing assessment, subjective and objective data should be obtained from physical examination, Gordon's typology, and chest X-ray findings. Nursing diagnosis. Based on the assessment data, the major nursing diagnosis may include the following: ineffective airway clearance related to tracheobronchial secretions, activity intolerance related to imbalanced nutrition less than body requirements, pain related to inflammatory process, risk for deficient fluid volume, planning and goal. The major goals include: 1. Improve airway patency. 2. Conservation of energy. 3. Normal breathing pattern. 4. No signs of hypoxia. 5. Maintenance of adequate nutrition. 6. No complications. Nursing interventions, nursing care. It is important for the nurse to remember that pneumonia is an acute infectious disease. Although most cases of pneumonia are potentially completely curable, complications can result. The nurse must be aware of these complications and their manifestations. The essential components of nursing care for patients with pneumonia include monitoring physical assessment parameters, facilitating laboratory diagnostic tests, providing and monitoring the patient's response to treatment. Along with physical assessment, including pulse oximetry monitoring, prompt collection of specimens, and prompt initiation of antibiotics within 4 hours of arriving at the hospital are critical. Oxygen therapy, administration of bronchodilators, hydration, nutritional support, and therapeutic positioning are part of the management of the patient. Lewis, the following highlights the nursing interventions or care given to patients with pneumonia. Improving airway patency. Removing secretions is important because retained secretions interfere with gas exchange and may slow recovery. Hydration. The nurse encourages hydration 2 to 3 days because adequate hydration thins and loosens pulmonary secretions. Hydration must be achieved more slowly and with careful monitoring in patients with pre-existing conditions such as heart failure. Brunner and Sudat, 2008. Oxygen and humidification. If the inflammatory process is far advanced, a patient may have considerable respiratory difficulty. Pharmakinwa, 2002. Humidification may be used to loosen secretions and improve ventilation. A high humidity face mask using either compressed air or 02 delivers warm, humidified air to the tracheobronchial tree, helps to liquefy secretions, and relieves tracheobronchial irritation. The nurse administers oxygen therapy as prescribed. The effectiveness of oxygen therapy is monitored by improvement in clinical signs and symptoms, patient's comfort, and oxygen values as measured by pulse oximetry or arterial blood gas analysis. Cough mechanism. Coughing can be initiated voluntarily or by reflex. Lung expansion maneuvers, such as deep breathing with an incentive spirometer, may induce a cough. A directed cough may be necessary to improve airway potency. The nurse encourages the patients to perform an effective directed cough, which includes correct positioning, a deep inspiratory maneuver, glottis closure, contraction of expiratory mucus against the closed glottis, sudden glottis opening, and an explosive expiration. In some cases, the nurse may assist the patient by placing both hands on the lower rib cage, either anteriorly or posteriorly, to focus the patient on a slow deep breath, and then manually assisting the patient by applying constant external pressure during the expiratory phase. Brunner and Sudat, 2008. Therapeutic positioning or chest physiotherapy. Therapeutic positioning identifies the best position for the patient to assure stable oxygenation status. The concepts of therapeutic positioning are based on type of lung disease and patient's response to positioning. The good lung down position is utilized for patients with unilateral lung disease in whom better oxygenation is achieved when the unaffected lung, good lung, is placed in the down lateral position. For bilateral lung disease, research indicates that positioning the patients with the right lung down provides the best ventilation and perfusion. The use of bronchial hygiene techniques, postural drainage, percussion, vibration is generally warranted unless the patient is producing large volumes of sputum, greater than 30 ml per day, or has X-ray evidence of mucus plunging and lobar collapse. Intensive spirometry, turning, coughing, and deep breathing all increase lung volume, mobilize secretions, and prevent atelectasis. Exercise and early ambulation augment bronchial hygiene and are encouraged as tolerated. Lewis et al., 2007. Chest physiotherapy, percussion, and postural drainage is important in loosening and mobilizing secretions. Indications for chest physiotherapy include sputum retention, not responsive to spontaneous or directed cough, a history of pulmonary problems previously treated with chest physiotherapy, continued evidence of retained secretions, decreased or abnormal chest X-ray findings, consistent with atelectasis or infiltrate, and deterioration in oxygenation. The patient is placed in the proper positioning to drain the involved lung segment, and then the chest is percussed and vibrated either manually or with a mechanical percussor. After each position change, the nurse encourages the patient to breathe deeply and cough. If the patient is too weak to cough effectively, the nurse may need to remove the mucus by nasotracheal suctioning. It may take time for secretions to mobilize and move into the central airways for expectoration. Therefore, it is important for the nurse to monitor the patient for cough and sputum production after the completion of chest physiotherapy. Airway suctioning. Following therapeutic positioning or chest physiotherapy, suctioning can be done for patients with suppressed coughing mechanism with copious tracheobronchial mucus plunging secretions. Pain management. Pleuritic pain occurs in pneumonia due to the inflammatory process. Effective pain control or management is important to enhance patient's comfort and to release discomfort. The nurse performs a comprehensive assessment of pain to include location, characteristics, onset, duration, severity, frequency, quality, or intensity of pain, and precipitating factors in order to determine appropriate interventions. Non-pharmacological technique, e.g., relaxation, guided imaging, music therapy, and distraction are used to relieve pain. The nurse administers the prescribed medications, especially the analgesics, to relieve pain. Promoting rest and conserving energy. The nurse encourages debilitated patients to rest and avoid overexertion and possible exacerbation of symptoms. The patient should assume a comfortable position to promote rest and breathing, semi-Fowler's position, and to change positions frequently to enhance secretion, clearance, and ventilation and perfusion in the lungs. Nursing care is planned simultaneously, thus allowing for uninterrupted rest periods. Rest enhances mobilization of body defenses so that the patients will have enough to fight against the invading organisms. It is important to instruct outpatients not to overexert themselves and to engage in only moderate activity during the initial phases of treatment. Promoting fluid intake. The respiratory rate of patients with pneumonia increases because of the increased workload imposed by labor breathing and fever. An increased respiratory rate leads to an increase in insensible fluid loss during exhalation and can lead to dehydration. Therefore, it is important to encourage increased fluid intake, at least 2 L per day, unless contraindicated. Oral fluids are generally ordered for the acutely ill patients as soon as they can be tolerated. Records of intake and outputs must be kept. Famakinwa, 2002. Maintaining nutrition. Many patients with shortness of breath and fatigue have a decreased appetite and consume only fluids. Fluids with electrolytes may help provide fluid, calories, and electrolytes. Intravenous fluids and nutrients may be administered if necessary. Also, high nourishing diet consisting high proteins and vitamins is rewardable for the replacement of lost tissue and for the building of its resistance to infection. Physical care. Self-care, oral hygiene, bed bath, etc. should be carried out for debilitated or patients that are seriously ill to ensure that the patients feel comfortable while pressure soars and other complications of immobility are prevented. Administering medication. Antibiotics and other prescribed drugs are administered by the nurse and their side effects are monitored. Health education, promoting patients' knowledge. The nurse helps in promoting the knowledge of the patients and community by health educating and instructing them about the cause of pneumonia, management, and symptoms. Signs and symptoms that should be reported to the physician or nurse and the need for follow-up. The patient is also informed about factors, both patient's risk factor and external factors that may have contributed to development of pneumonia and strategies to promote recovery and prevent recurrence. Monitoring and managing potential complications. The patient is observed for response to antibiotics therapy. Usually, patients begin to respond to treatment within 24 to 48 hours after antibiotic therapy is initiated. The patient is monitored for changes in physical status, deterioration of condition, or resolution of symptoms. For persistent recurrent fever, which may be a result of medication allergy, medication resistance, or slow response greater than 48 hours of the susceptible organism to therapy, superinfection, pleural effusion, or pneumonia caused by an unusual organism. Failure of the pneumonia to resolve or persistence of symptoms despite changes on the X-ray raises the suspicion of other underlying disorders, such as lung cancer. In addition to monitoring for continuing symptoms of pneumonia, the nurse also monitors for other complications, such as shock and multisystem failure and atelectasis, which may develop during the first few days of antibiotic treatment. Brunner and Sudat, 2008. Health promotion activities. Good health habits such as proper hygiene, adequate diet, rest, and regular exercises. All these maintain natural resistance to infective organisms. Health promotion activities. 2. Prompt treatment of upper respiratory tract infection with supportive measure, usually with fluids and rest. But if symptoms persist for more than 7 days, medical treatment should be encouraged. 3. In hospitalization, identify patients of risk of pneumonia and take adequate measures to prevent its development, such as 4. Frequent turning of unconscious patients. 5. Positioning of intubated patients in semi-recumbent position, particularly during enteral feeding. American Thoracic Society, ATS. 6. For patients on tube feeding, oral tube is preferable to nasal tubes to prevent nosocomial sinusitis. Summary. In this study, we have learned that hospital-acquired pneumonia is more likely to be caused by Staphylococcus aureus or a gram-negative bacterium such as Klebsiella pneumonia. Depending on the affecting organism, there is usually a difference in the severity of pneumonia and the way it is treated. Mark, Andrew, Thomas, et al., 2003. The treatment of pneumonia is administration of the appropriate antibiotics as determined by the results of the Gram stain. Penicillin G is clearly the antibiotic of choice for infection with S. pneumonia. Other effective medications include erythromycin, clindamycin, the second and third generation cephalosporin, etc. It is important for the nurse to remember that pneumonia is an acute infectious disease. Although most cases of pneumonia are potentially completely curable, complications can result. The nurse must be aware of these complications and their manifestations. The essential components of nursing care for patients with pneumonia include monitoring physical assessment parameters, facilitating laboratory diagnostic tests, providing and monitoring the patient's response to treatment. End of study session 17. Thanks for listening.